Ah, there it is. So here comes our very first poll results. Gosh, boy, what that is really boring. So most people right now are in their office, and no one. Oh, there are a couple of people that where you just don't want to know. Well, listen, ladies and gentlemen, wherever you are, here, there, hither, thither, or yon, especially yon, welcome to the very first DFCONtinuum. I'm David Armstrong. I'm a professor of surgery at the Keck School of Medicine of the University of Southern California. It is such a pleasure to be with you. We have, as you know, I'm preaching to the converted when I tell all of you that this has been an extraordinary year. That is almost like a proverbial now, but we've tried to beat, we've tried to meet the year where it is. That is for us to be able to come together, especially when the world is sort of forcing us apart. And we got to do that not only for each other, but for our patients. And our big goal, of course, with DEFCON has been to try to eliminate preventable amputations over this and the next generation, and also to help our patients move through the world a little bit better. And on behalf of my co-chairs, Mike Conti, Joe Mills, Bijan Najafi, Laura Shin, it's such a pleasure to be with you today. This is the first of the DFCONtinuum series where we're taking really interesting little snippets from DEFCON and kind of expanding on them, kind of developing them. And I can't think of a better place to start than from our posters. So our posters are often from our up and coming men and women in medicine, surgery, and engineering and science in this area. And they really are very often compelling, and they're designed to change your perspective. And it's my pleasure right now to introduce the first poster presentation, and that's going to be straight out of Pisa. If you don't know, so much of the way we take care of patients in terms of teams, in terms of the toe and flow, in terms of care, has come from Northern Italy, really, from select units there by men and women who have been real pioneers in this area in teaming up. And these are physicians, these are surgeons, and scientists. And the very first person that's going to be presenting is one of those people, and that's Elisabetta Iacopi. And Elisabetta is part of just a world-renowned team, and she's one of the real anchors there. Just ask one of her mentors, my friend Alberto Piaggesi, and she'll tell you. But her award was the first place award. And we're going to start with that first place award, the gold award from this last DEFCON, which is a really compelling question. And it's in the title. I fear COVID, but I fear diabetic foot much more. Results of a survey on telemedicine service for the diabetic foot during the pandemic. Ladies and gentlemen, straight out of Pisa, Dr. Elisabetta Iacopi.
Hi, thank you. Thank you, Professor Armstrong and Professor Najafi. Thank you, DFCON, to giving me this opportunity to present to you. This is very important for us study. So, as you yet said, our idea was to evaluate the fear of our patients versus COVID and versus diabetic foot, and we perform it through a survey on telemedicine service that we implemented during the first lockdown and the pandemic. As well known, at the end of 2019, the China government speaks about a reported notice about a cluster of cases of pneumonia in the seafood wholesale market in the Hubei province at Wuhan. And in the few days, they confirmed that these cases were due to a novel coronavirus called SARS-CoV-2. What happened in the next months is history. The virus spreads all around the world, giving rise into a pandemic that had infected more than 70 million of people and that killed more than 1.5 of them. So in such conditions, the face-to-face visit were to be reserved to urgent and emergent condition, also in chronic example. In such cases, Tuscan health authorities give us the possibility to continue to take contact with our patients and to manage their chronic disease through a dedicated system of telemedicine. So the aim of our study was exactly to evaluate the perception of telemedicine in our diabetic foot patients during the COVID, and to evaluate the level of anxiety, not only to COVID as expected, but also to the chronic disease they suffered. During the first Italian lockdown in the month of March and April 2020, all patients were reached by daily televisit performed by the staff of the outpatient clinic, all that patients that cannot perform traditional visits in hospital. In the month of May, the patients were newly contacted to submitting them a questionnaire. The questionnaire, here reported, was composed by two different parts. In the first part, we went to evaluate the characteristic of the telemedicine contact, what patients remember regarding the contact itself, if the patients remember to have been contacted, if they remember with whom they had spoken among the different persons they know in the outpatient clinic staff. If we ask them if they remember the issue of the contact, and eventually to analyze the system, the availability of caregivers for the patients, we ask them if they were alone during the telemedicine contact, or if some relatives were with them. In the second part of the visit, we aim to analyze the satisfaction of patients regarding the contact, and eventually the fear versus diabetic foot and versus COVID. We perform that, asking to the patient to assign a score ranging from 1, not at all, to 5, that means completely yes, to the satisfaction versus the usefulness of the visits in regarding to their health condition, to the usefulness of information that outpatient staff given them, to the possibility to, and their eventual interest to continue this modality of contact also after the lockdown and after the end of pandemic. Eventually, we asked them how much they worries both diabetic foot and COVID. Going to results, we can say that we performed 257 televisits, which were performed only in patients without urgent condition that continues obviously to be followed in traditional visits in the clinic, in 211 patients. In the month of May, 206 patients accepted to be newly interviewed. The newly interviewed patients were at a mean age of 72 years, as expected in a traditional diabetic foot clinic population, were predominantly male, 64% of them. They had a mean duration of diabetes of 18 years, and they were followed by diabetic foot clinic since a mean of 12 years before then the lockdown. The first part of results analyzed what patient remembers. We observed that 85% of them remembered to have been contacted during the lockdown, and among those patients, 67% of them remember the person who had spoken with them, and 87% of patients remember the issue, the argument of the contact. We went then to search for differences among patients who remember and who did not remember the characteristic, the details of the call. We can observe, first of all, that patients who remember the call were predominantly female, were tended to be younger, and the characteristic below is that all patients with a previous amputation remember to have been contacted during the lockdown. Analyzing instead regarding the patients who remember the reason, the issue of the call, we could observe that patients who remember the call, the reason of the call, were once again predominantly female, and once again were younger as expected. Eventually, the level of satisfaction of our patients regarding the characteristic and the usefulness of the call. You have to consider that this characteristic, where this score was given, as I said, on a range going from 1, not at all, to 5, completely. 4.35% was the score assigned to the usefulness of the phone call, according to the patient. 4.11 was the usefulness of the indication that the staff ambulatory give to patients during the call, and 4.34% was the usefulness that patients assigned to the possibility to continue with this contact modality besides the normal traditional contact and traditional visit modalities after the end of lockdown. And this is exactly what give us the possibility and the idea to continue with this modality, with this still now active in our outpatient clinic, obviously now besides to the normal traditional visits. Eventually, the fear of our patients. So those are patients regularly followed in our outpatient clinic. So probably the fear for the diabetic foot is obviously more, is higher than a normal general population of diabetic patients. But we could observe that in general population of our diabetic foot patients, the fear for diabetic foot is very higher if compared to the fear for COVID. And this fear, this gap, is higher when we selected an higher risk population from the general population, only the patients with the previous ulcer, previous active diabetic foot problem. And the gap become even higher when we selected the higher risk population, the population of previously that had had a previous amputation. The characteristic is that the difference between the gaps is significantly, statistically significant, as if patients who had to fear diabetic foot because we teach them to fear diabetic foot had not possibility to fear at the same level any other critical health condition. So in conclusion, the telemedicine service that Tuscany implemented during the recent pandemic was very appreciated by the majority of our chronic patients, and them, however, continues until now, after an hour of COVID pandemic, to fear more diabetic foot than COVID. Thank you.
Hi, Elisabetta, that was a terrific presentation, and just absolutely perfect for the times we're living in right now, in the second surge, as it were. And let's start, some of these discussions. Maybe 5 or 10 years ago, there was a manuscript by my friend and colleague Dane Wukic and co-workers that suggested that patients with diabetes feared amputation more than death. And has that been something that you have found for your patients, even during the pandemic? And has that changed how you treat your patients and how you talk to them?
I think that the pandemic has changed our idea to try to make them autonomous, to make them understand that the first diabetic foot specialist should be the patient, the same pathway that diabetologists that follow our patients for diabetic management, followed since many years. The take care of your diabetes, and now we have to teach them to take care of their diabetic foot, because
right.
This fear, we can use this fear that they had demonstrated to help us to help them.
Yeah, that's perfect. And so years ago, there were some studies that came out in the late 1980s from colleagues of mine in Arizona. This is, I think, 1989 maybe, and that suggested that when they gave patients sort of frightening photographs and discussed with them basically scared them, that seemed to have a greater impact on on whether they remembered aspects of diabetic foot care and possibly even their outcomes. Now, we may not agree with how aggressive, these clinicians were at the time, but you're saying maybe with a little bit more thought what they were talking about back then, right? That maybe there's just a little bit, if we just need to increase the threat level a little bit in their mind, right? And is this what you're doing right now to them?
I think that the real challenge for us should be increase the fear in patients at not so high risk of diabetic foot in the general diabetes population, because it's quite easy to understand that patient that had that previous ulcers, a previous amputation is terrifying for recurrence, because we every day say them that the recurrence are so high, you have to take care of your feet, you have to take care of your toe flow, to use your shoe we prescribe you. Perfect. We are very, very impacting in teach them to fear a new episode, but we are not so good, not so useful in teach to patients with no previous ulcers to fear the first ulcer.
Yeah. Well, there you are. I think that that's part of how do we appropriately dose our consultation with them and things like fear. We talk about this, and we've talked about this. We compare this problem to cancer with many of our patients, and we tell them that, and we just share with them the data that this can shorten their life, and it does. Like many cancers, these ulcers do. Certainly, amputations do. There are now abundant data to show that. And maybe doing that and dosing those sessions that we share with them when we're seeing them earlier may even be a little bit better, even though many of our patients might just turn it off, maybe just continuing to sort of repeat this. I want to bring in Bijan Najafi on this as well. So because Bijan and I actually have a grant out right now between our institutions, between USC in Los Angeles and Houston and Baylor, where we're looking at ways to promote people to be adherent, to be compliant, if you will, with their offloading. And what you're talking about, Elisabetta, is right up that alley. Bijan, you want to kind of chime in a little bit on your take on this and maybe how we can use some of the data from Elisabetta to move forward and make a difference?
Sure, absolutely. I mean, as you mentioned, COVID-19, of course, devastated many healthcare systems. But I'm seeing some positive things. I believe that at the same time, COVID-19 can change the healthcare system as well. And part of it is also, as you mentioned, engaging the patient to be part of the health ecosystem, because currently, so far, we consider patient as a passive recipient of the care rather than active recipient. And anything that we can help the patient to educate them and empower them to understand and to be engaged, that would be very valuable. And definitely telemedicine, remote patient monitoring, I believe is the future. We are in infancy, but I believe that the pandemic can accelerate them. So my question to Elisabetta is that, what do you think about telemedicine? How we can encourage patients with diabetes to utilize telemedicine? What are the hurdle currently that we have? And do you think that we know that they may have more fear of the diabetic foot and less fear of COVID-19, but of course the fear of COVID-19 still is present. We think that that fear also can maybe make these patients more keen to what the technology and telemedicine and remote patient monitoring?
So what I can say is that for us, when we perform the telemedicine contact, we are very interested in the reaction of patients and of their caregivers in adequate to be able to contact us. So they were interested in learn, for example, the sites, the application for the phone, for the smartphone. They were very interesting in to help us to contact them, because they were aware that it was not possible to reach us directly face to face for not urgent condition or emergent condition. And they were, I think, very interested in not reach the condition that requested them to come directly in the clinic. So every dispositive, every application, every possibility to contact us and to have a contact, to maintain the contact with us. When I think that it's an experience that all of us that manage diabetic foot experience every day. Patients are take care of you as you take care of them, because you follow them, you see them once, twice a week, twice a month or so. Also for chronic patients with no acute episode, especially if they had the acute episode and they suppose in their mind that you help them. They are very proud of you, very grateful to you. So to contact you is for them also a way to be more safe. They feel more safe when you see them and when you see their feet.
Yeah,
absolutely. I mean, this connected health, I believe that is future. So unfortunately, we are running into time, and we may move on to the next presentation if it's okay with everybody. But please, everybody, send your questions.
Hey, Bijan, you didn't ask if it was okay with me or with Elisabetta.
Yes.
But okay, it's okay. There's so much more to discuss.
It is amazing. I mean, all these three talks are amazing, and all of them, they are connected with each other. And
you can just develop this so much.
Let's continue the conversation again. Everybody, please send the questions. We will share with everybody. I hear actually from Elisabetta that her paper now has been accepted for publication. So definitely in her publication would be more details. Elisabetta, could you quickly mention that which journal published your paper, and maybe you can share on the text box the citations so that people can look at that.
The final steps for publication in Acta Diabetologica.
Okay, fantastic. Congratulations.
So
Acta Diabetologica, we have to publish there a little bit more. You know, I don't know if we ever have, and it seems like such a sophisticated journal. It just sounds great, doesn't it? Acta Diabetologica. It's always been around, just a little bit exotic. We have to publish there now. We have to work on this. Bijan.
Sure.
Note from Elisabetta. Acta. Act up.
Okay, ladies and gentlemen, greeting from Houston, Texas. I have great pleasure to introduce the next speaker. And after the fantastic presentation of the first speaker from Elisabetta from Italy, now we come back also to Houston. The next talk somehow also related to COVID-19 pandemic. As I mentioned, I believe that as healthcare providers searching for alternatives to deliver effective care to patients with diabetic foot ulcer, I tempted to imagine that post-COVID future maybe lead to some positive changes in healthcare, in particular for the patient with diabetes. And the attitude is changing, the technology is improving, and the speed of the transition of the technology is improving. And one of those technology could be the technology that patient can be used at home and can help healing of their wounds. And that technology is electrical stimulation. Of course, David Armstrong probably was one of the leaders on using electrical stimulation for wound healing, but finally the technology came at the level that the patient can use it at home without even removing the dressing. And it seems that can help them to take care of the wound, speed up the wound healing, and maybe reduce the frequency of the need to come to clinic. And during this COVID-19 pandemic, we desperately needed those technology because, as you know, those patients that are highly vulnerable, and we would like to reduce the number of needed visits to come to clinic. And the next speaker actually covering that talk, the next speaker is Dr. Alejandro Zulbaran. Actually, he's from my institution, my division. Alejandro, quick biography about him. Alejandro is an international medical graduate from Central Mexico, graduated in 2018, who came to the United States to perform his medical clerkship in 2016. And then he became research volunteers at the Baylor College of Medicine, Division of Vascular Surgery and Endovascular Therapy in Houston, Texas, for 1 year. During his time with Baylor College of Medicine, he showed great initiative and was outstanding intern in Division of Vascular Surgery. After he obtained his medical license in Mexico, he come back to Houston, and now he became as a researcher in the division. He's now working for his residency, he's pre-resident, and is involved already in many research in the area of the surgery, and in particular in the area of the vascular surgery and also wound healing. So his talk, it's entitled as Effectiveness of Daily Home Electrical Stimulation as Adjunctive Therapy to Accelerate Wound Healing in People with Diabetic Foot Ulcer, a double-blinded randomized controlled trial. Alejandro, the podium is yours.
Thank you, Dr. Najafi, and good morning, everyone. Let me share my screen. Okay. All right. So thank you for your kind words, Dr. Najafi, and thank you for Dr. Armstrong and for the board from DEFCON to letting us present our work today. It's really an honor to be on the award session, on the first award session of this webinar. And the names here in the first slide are from key people were key instrumental to develop this study. I would also like to thank all the MAs and other coordinators that make this study possible. It was really like a big teamwork. As Dr. Najafi says today, I'm going to present the effectiveness of electrical stimulation to improve wound healing in diabetic patients. Just sorry, I need to read. All right, my apologies for that. So this study was supported in part by a grant from Avacia Inc. It was a company located in Texas, in Dallas, actually. So as a brief background, diabetic foot ulcer, as we all know, is a severe worldwide problem, especially in the US. The cost for DFU is comparable to cancer. This is actually an image from Dr. Armstrong's publication in the New England Journal of Medicine. The recurrence for diabetic foot ulcers at 5 years is 65%. So it's really high, as Dr. Iacopi just mentioned in her clinic. Just a little physiology. Foot ulcers rely on repetitive stress over an area that is subject to high vertical or shear stress. It begins with a calcium formation, then continues with a subcutaneous hemorrhage, and finally ends with tissue loss. And once an ulcer is present, an ability to self-repair in a timely manner accompanies. So normally the dermal layer keeps a skin battery across the body through ionic movement, generating a polarity with a positive and negative poles presented here in figure A. When a wound is present, as shown here in picture B, the current flows out of the injured skin, as you can see in these blue arrows, and creating an electrical potential that guides epithelial cell migration, as seen in these green arrows. And technologies such as electrical stimulation have been introduced as an adjunctive therapy for the management of wounds. These consist in a current through electrodes that run through the skin, which in the presence of a wound generates an electrical leak that produces short circuit in impulses to flow out the moisture. So today there's evidence out that says that electrical stimulation is associated with angiogenesis. Preclinical and human studies have demonstrated this. There's a vast majority of studies in the last 2 decades about this. Below are all the phases of wound healing under the regimen of steam. As you can see in the inflammatory phase, we have increased blood flow, tissue oxygenation, decreasing of edema. Then we come to the proliferative phase, where there's an increase of membrane transport, collagen matrix organization, and other factors. And finally, we have the remodeling phase, where the increase in epidermal cell reproduction and increase of fibroblast stimulation occurs. There's also a lot of theories or a lot of evidence that have demonstrated that e-steam can help from cell migration attracted from by the polarity of electrical fields. And there's studies, randomized control trials, prospective studies that have demonstrated this effectiveness in reducing wound size in venous and also in arterial disease. And current literature, there's a decent amount of evidence that support the use of e-steam, especially in human trials. However, there's a lot of studies that are not including daily home-based type devices, and there's lack of objective measurements. Also in contemporary healthcare, a modality of treatment, time and dosage are suboptimal, and this creates a little controversy to the best applicable protocol. The authors of this review also say that better designed clinical trials are needed to improve the understanding of e-steam. So this leads us to some barriers of the application of e-steam in a clinical setting. The first one is its administration under supervised condition by trained care providers or by health providers on the clinic. Second one is electrode pads placement, which are often applied close or over the wound bed. This requires constant dressing removal, and this creates or increases the likelihood of infection. And the third place we have its administration. It's mostly in hospital and clinical setting. These making the efficacy of therapy depending on the presential and compliance of the patients. We were actually previously saying that compliance is a big problem in these kind of patients. And finally, the administration in painful areas or electroshock insensitivity may cause discomfort in some patients. So to address this barrier, we propose the use of e-steam in a home-based daily manner above the ankle. So we avoid placing it close to the wounds and all these dressing changes, and to improve wound healing with a portable device that patients are able to take home. And our hypothesis is that this modality is feasible, effective, and acceptable to improve wound healing and tissue oxygenation in this kind of patients. So we designed a randomized control trial, including 38 patients for 4 weeks. Patients were categorized as intervention and control groups depending on the use of either a functional or non-functional device. Differences in functionality of devices was barely perceived by patients due to the high volume of peripheral neuropathy in our population sample. Stimulation was provided through adhesive pads placed above the ankle level, as shown here. Therapy was given for 1 hour every day for a duration of 4 weeks, and coordinators and podiatrists would assess in a weekly manner all these outcomes. The primary outcome was wound size. We were measured with a specialized 3D camera that detects the length, width, and depth of wounds. The secondary outcome was tissue oxygenation, assessed with a novel system able to detect saturation of oxygen by near-infrared spectroscopy. Results show our baseline demographics had no significant differences between groups, showing a fair comparison. We included patients of different types, additional to diabetes. We have CKD patients. We don't have ESRD due to the hemolysis. But we also have dyslipidemia, heart disease, peripheral artery disease, and also we included patients with minor amputations or previous revascularizations. The only thing that was actually significantly different between groups was the wound size, which we adjusted as a potential confounder when performing our general analysis. Aligned with our hypothesis, results show a faster speed of wound healing area in the intervention group compared to the control group. After 4 weeks of therapy, there was a higher daily rate of wound healing in intervention group with a 39% faster than the control group. Also, the intervention group showed a 37% faster change in wound area at 4 weeks compared to the control group. At 4 weeks, time per group analysis showed a 22% significant improvement in favor of the intervention group after adjusting by potential confounders. In fact, the control group size wound increased. Also, we found a significant 40% reduction in wound depth in the intervention group compared to the control group at 4 weeks. Overall saturation of oxygen comparison between baseline and 4 weeks and between both groups and within groups was not significant. However, when including only patients with an ankle brachial index below 0.8 or more than 1.4, we labeled these patients as moderate to severe PAD. So this subgroup showed a baseline saturation of oxygen below 75% after classifying them, and they reveal a significant improvement with daily home-based STIM as comparing control group with intervention group. Also, the degree to which participants improved SATO2 were directly related to the initial outcomes. Initial SATO2 shows significant negative correlation with change in saturation between the two endpoints. Intervention group patients who had lower saturation of oxygen at baseline showed higher gain in compared to the control group, and this pattern was more prominently seen in the subgroup of patients with moderate to severe PAD. We also included these results have been already accepted for publications in the Journal of the American Podiatric Medical Association. This is part of the study. We evaluate 1 hour of this STIM in all these patients, and every half hour we would evaluate saturation of oxygen. As you can see, it's increased, and we stop therapy and it decreased for a little, but it maintained significant compared to the baseline saturation. So this is an intervention group case. As you can see, there's an area reduction of 92% at 4 weeks. This is a weekly assessment that the software of the camera gives us. Below you have also saturation of oxygen. This is how the near infrared looks, and this is how we assess all these areas of ischemia at 4 weeks. This is a control group. Actually was 0% of increase. This is just a comparison. And we also evaluate acceptability of device. 81% of the patients were able to complete the survey. We have almost 77% of patients saying that it was easy to use and that they felt their wound was healing faster. And also more than 90% of patients would recommend it to a friend or would use it again. So in conclusion, this is the first double-blind randomized control trial demonstrating feasibility and efficacy of daily home STIM to improve wound healing. The self-report adherence to home therapy was over 90%, indicating high acceptability of this approach. And results evidence the positive contribution of STIM to improve tissue oxygenation, which is a key for wound healing. Thank you.
Excellent work, Alejandro. Thank you so much for this true presentation and also presenting some of the outcomes that's quite innovative, like oxygen saturation that everybody are talking about it. So I hear that there was, it seems, a little problem with your microphone. Sometimes the voice is coming low and high. So please, everybody, if you have any questions or anything that was not clear, please send your question to the chat box. Alejandro, I have a question for you. I mean, I'm seeing that you place the electrode to the ankle joint rather than close to the wound. We think that maybe for electrical stimulation to work, we should place the electrode of electrical stimulation very close to the wound. So can you explain the rationale why you are selecting ankle joint instead of bottom of the feet for position of the electrical stimulation electrodes?
Yes, that's a great question. So basically, from all the evidence that we have out there, most of the studies that have published good results about e-stim were almost placed around the wound or over the wound. These create some sort of gaps. The first one is that patients are not able uh, to place the electrode pads. It's a little hard for them, you know, to go down and try to find a place where they are not touching the skin borders. And the second one would be, as I mentioned in the introduction, the lack of infection. There's a lot of patients that actually have negative wound pressure therapy, and it's hard for a patient to even take it out and place it again. This has to be done by a health provider, by a health specialist. And also there's a couple of publications that have used electrical stimulation at the ankle level, not for wound healing or other purposes, but we select this one in these points where they're called acupuncture joints, joint points, which are previously published, and we based this decision on that publication that actually for that particular study, they were evaluating pain in these kind of patients that were very, very similar to our cohort.
So location does matter, it seems. So I have a great questions coming from the audience. One question to talk about, do you believe that we may find a dose response to this technology? And maybe you can expand this. I mean, what should be the magnitude of electrical stimulation to be effective, or whether the type of the waveform that you are using is effective, and whether we should use daily basis or whether we should use, for example, single application per day. So what is your thought on that?
So yeah, that's a great question also. And yeah, exactly, that's what I was, well, that's one of the gaps also, that there's not a dosage or like the best applicable protocol. So we used the intensity of our devices were between 150 and 250 volts, which is a high voltage pulsed alternative current. This is the one that we selected. We made some tests before with healthy subjects. We also evaluate fatigue for a 1 hour in a subject, and we have engineers here that evaluate the muscle activation or muscle activity with EMGs, and we compare actually fatigue in healthy subjects. So also every week when we would evaluate these patients, we have a survey for them asking, hey, how do you feel? How is the fatigue? Does it hurt? Do you think it's actually working? So we were adapting all these features throughout all the study. But talking about also the waveform, we use a special waveform that is called damping session, that it's in our device, on that device is called infinity mode. All these features are explained in a better manner in the manuscript. It's gonna be out there soon. I will be happy to share it. But we included all the features related to the damping, to the dosage, which waveform did we use. And to your third question, well, for now, patients used 1 hour of e-stim every day, but there are some patients that would use it more than 1 hour, maybe a couple of hours, maybe even 3 hours, not continuously, but they would use it throughout the days. And there's other patients that actually have bilateral pain. Maybe in one foot they have a wound where we were applying e-stim. Maybe in the other foot they would have only pain, and they would just use the device in the other foot to alleviate pain. So this is how we're being exploring the use of the device with this dosage.
So we have so many questions that came, so I really appreciate if you can be short on some of your answer. Another question that I'm seeing here is that, thank you for your interesting presentation. Was local treatment standardized?
Yes, I mean, this is what exactly where we expected for all patients. We use the same voltage, the same place for all, and the same time.
Okay, and somebody mentioned that it's very interesting to see the application of the home use and its safety. About safety, do you have maybe any comments saying that whether, for example, does matter that if the patient who has numbness maybe increase too much the magnitude of a stimulation, whether there is some recommendation? I'm seeing that also some of your patient has kidney failure. There is a question that whether electrical stimulation maybe can, I don't know, change some of the factor that may lead to renal failure. Can you elaborate a little more on the safety issue?
Yeah, so for safety, most of our patients had peripheral neuropathy, so they weren't able to actually feel the stim. So those kind of patients would elevate the intensity of the device to the superior limit. We would say 250 volts. Also, these devices have been FDA approved for pain and for these for this dose, so they are considered safe. And for patients with renal failure, well, we were seeing them every week, and I mean, it wasn't let's say a big deal for them to have it there. They're being screened for blood tests and for other factors that actually the podiatrists are constantly revising. So there were major changes in any of the blood levels of these patients. So for now, we can say that as long as we use this dosage, it has been proved to be safe.
Great point. So I'm seeing also another question about fatigue that mentioning on that level. Of course, I'm assuming that you are not necessarily activate muscle to be concerned about the fatigue of the muscle, but just I know that we just got an IRB approval to use this technology to prevent muscle atrophy on COVID patients who are in the ICU at bed bound, and definitely that fatigue become relevant. So I'm seeing that Dr. Sheen is online. I don't know, Dr. Sheen, what do you think about some of those kind of the potential? Dr. Zulbaran actually shown some background about some of the, I don't know, basic science research and even the potential of improving tissue perfusion, tissue oxygen level that may manage some of the infection. Dr. Shin, do you have any comments, maybe from your expertise point of view? What do you think about the use of those technology to maybe promote some home adjunctive therapy for those patients with active foot ulcer?
I think this was actually a fascinating conversation, because we talk about that and not having that active ulceration and not having that sensation, and we find especially when we do our remission clinic that the patients kind of get into trouble again because they don't have that stimulation therapy. And so I can see some really great uses in like as soon as we're sort of done with the acute care needs for the long-term follow-up, and keeping them kind of getting that awareness again, and not only training them through offloading devices and other aspects, but also using this kind of therapy maybe to even help restore some of that tissue and restore some of that neuropathy maybe in the foot, in those areas, in those high risk areas.
Yeah, and you're actually joining us, Dr. Shin, from the remission clinic, aren't you?
Yep. From the
Right.
vascular lab, I have to.
Oh, there you are. You're in the lab right now. So hello to you. That's terrific.
If I try to
coming out here.
If I try to take the Zooms at home, I got to sit in the closet because my 3-year-old wants to
Oh, yeah. Well, you use your 3-year-old's computer, or the older. It's actually it's never. Anyway, close enough. This is great. Alejandro, thank you. This has been a terrific talk. Are there any other questions, Bijan? Because I know there were a ton
There
of
are
them.
several questions. I'm a
Yeah,
little
why don't you
worried
hit on
about the
these?
time.
Sorry to
But
butt in.
Respond them,
I may ask,
in the chat.
yes. I may ask actually maybe the last question and then we can move on. Actually, there is a great question that said that you think that the electrical stimulation and impact of muscle contraction will have benefits of the secreted myokines on generalized body healing and cardiovascular improvement. That's coming from my friend, Mr. Dr. Menzies. Thank you for that very difficult question. You tested my ability to read some clinical terminology. Thank you so much. Alejandro, do you have any comment on that?
That's actually a great question. So as we place these electrode pads at the ankle level, we are not actually activating the lower extremity muscles, but as Dr. Najafi says, we just got IRB approval to apply them actually in all the gastrocnemius in the Achilles tendon, and so that's where we are actually trying to help this patient for muscle atrophy, for secreted myokines on generalized body health, healing and cardiovascular improvements. I would right now I wouldn't have an answer for that, honestly. That's a very good thing to look in the future.
Thank you so much. So Dr. Sheen, the audience is yours, the panel is yours. So looking forward to the next presentation. Thank you so much, Dr. Zulbaran. Great talk.
Thank you, Dr. Zulbaran. That was excellent. It's good to see everybody, especially internationally. It feels like, we haven't seen each other in so long, but having these Zoom meetings and this continuation of education is really inspiring. I think that the DEFCON forum has been really incredible, and what it's taught us that, universally with COVID, with everything else that's going on, we really need to find a way to connect with our patients. And our next poster, I'm very proud to actually be one of his mentees. He was one of my mentors when I was at Scholl. He is from Rosalind, Franklin. I'm very, very, very excited to introduce Ryan Cruz and all of the great works that they've been doing. He has been a part of the Scholl Institution now for quite some time, evaluating different technologies. And this poster represents how some of the different design features will really help our patients with stability and with ambulation. And so it's very, very, very exciting for me. And I'm really proud to be a part of this institution on how these different design features. One of the things that has really pushed our field forward, especially as clinicians, is this ability to marry technology, marry these different things into our everyday patients' lives. So I think a lot of times we have these technologies that are available to us, and how to incorporate them, is really a challenge. And so I will let Ryan explain and kind of go over his poster, and it's good to see you.
Great. Thanks for the kind introduction. It's a pleasure to be here. It's certainly been a tough year for all of us. And I think events like this are making it a little bit brighter here on the tail end, and looking forward to 2021. So obviously this talk here is defined, it's an offloading talk. When we talk about healing diabetic foot ulcers, there's two key things we need to take off these wounds. And I don't think this is new information to anybody on the call, but the first thing we need to do is get rid of any necrotic dead tissue. And then secondarily, again, the focus of this talk would be removing the physical trauma associated with these wounds forming in the first place. So when we talk about current standards and guidelines for offloading, the current guidelines have kind of a gold standard established with total contact cast or knee-high removable cast walkers that have been rendered irremovable. And then kind of the silver tier or second choice currently would be knee-high removable offloading devices. In contrast, though, to guidelines, current practice is much more common to see removable devices used. And some of the reasons why it's difficult to implement irremovable devices in clinic have to do with patient tolerance, cost of these devices, skill required to apply them, time required to apply them, as well as the limited access to wounds once a irremovable device is applied to a wound. So in talking about the removable devices that are used more frequently, we have seen in previous work, as one would expect, the more adherent somebody is to using a removable device when they're weight bearing, the more healing we see. Secondarily, in some of our prior research, we found that self-reported unsteadiness is a significant predictor of adherence. So those people that have challenges with stability are also less likely than to wear their offloading devices. So thinking about this problem a little bit more, if we're able to limit some of the disincentives of removable cast walkers, such as impacts on balance, imposed limb length discrepancies, the weight of these devices, we may ultimately be able to improve adherence. And so instead of asking folks to walk around in a pair of cement shoes, if we can get them a little more functional in their devices, we might get a little better outcomes for them. So in line with this, we're proposing that we start reframing some of these questions around offloading and not simply ask, will the device work for the wound, but more specifically, will the device work for the patient? And so some of our prior work looking into this has looked at just the size of the device. So there's traditional knee-high cast walkers, which again are the gold standard, and there's short leg walkers. And we've seen in prior work that short leg walkers can essentially provide similar offloading as the knee-high walker at a lower weight. And we've also seen that comfort and gait can improve with the use of a short leg walker with a contralateral limb lift, in contrast to the traditional knee-high cast walker without a lift. So the purpose of the specific study we're presenting this morning is to compare compensatory responses to perturbations in knee-high removable cast walkers versus short walkers with a contralateral lift. So for our participants, we had 18 participants. All the participants had diabetes. They had to be able to ambulate without any assistive devices. They also had to, at minimum, have diabetic neuropathy, but they may have also had additional risk factors for foot ulcers. For exclusion criteria, they were excluded if they had an active wound or an amputation more proximal than transmetatarsal, as well as previous treatment for a limb length discrepancy. As you can see in the participant descriptors, we had predominantly female participants, an older population with a mean age of 68. It's important to note here that over half of the participants had actually experienced a fall in the past year. And then in looking at their self-reported fear of falling, we can see that most of the participants had either moderate or high concern for falling. So for the study, in a randomized order, we evaluated stepping thresholds under 3 different footwear conditions. So we had a control condition, which consisted essentially of bilateral athletic shoes. Then we had the short walker with a contralateral shoe lift condition. And then lastly, again, the more traditional knee-high walker without a lift. And looking at stepping thresholds, we looked at them from 2 different perspectives as far as the types of perturbations that we applied to these folks. So we had waist pulls that were done in both anterior and posterior directions, as well as perturbations that were applied via treadmill. And those were done in anterior and lateral directions. And the next slide will go into these a little more detail. Lastly, in addition to the perturbations and stepping threshold test, we also asked participants just to evaluate how stable they actually felt in the various footwear conditions. And this was done by a 10-centimeter visual analog scale. So for the waist pull perturbations, these were done with a spring scale. And what happened was we loaded or applied a fixed load with a spring scale and then rapidly released that load. And over the course of trials, you did higher and higher loads until you reached a load in which the participant was forced to take a step in response to that load. For the treadmill perturbations, we did short little activations of the treadmill with a fixed acceleration. And then between the different trials, what changed was the maximum velocity reach for the trials. And again, we did multiple trials until we determined which velocity was required in order to elicit a stepping response. So in the videos here, you see one trial in which no stepping response was elicited. And then secondarily, you see a trial in which that stepping threshold was reached. And so this would be an example of the anterior directed treadmill test. And then as you can see in these next videos here, this is an example of the laterally applied perturbations on the treadmill. So for the results, across the 5 outcome measures, you can see that 3 of them reached statistical significance. So we had the anterior directed waist pull stepping threshold, as well as the anterior directed treadmill stepping threshold reaching significance, as well as the self-reported stability measure. And as we look across this table, what you can see consistently is outcomes were best in the short walker paired with a contralateral lift condition. And just to get some perspective on the size of the differences between the 2 offloading conditions, we have these Cohen's D values, which indicate that the magnitude of difference between the offloading conditions was moderate to high. So when we think about falling, ultimately the cause of the fall is the inability to initiate a proper recovery to a loss of balance. In this specific study, we showed that subjects at risk for diabetic foot ulceration with mostly moderate to high fear of falling showed better compensatory responses to perturbations when using a short-legged walker with a contralateral lift. Similarly, patients also perceive themselves to be more stable in that condition of a short-legged walker with a contralateral lift. Taking these steps beyond the lab, we may see these results start to translate to increased adherence and improved diabetic foot ulcer healing for patients. Playing off that point, it's important for providers to be mindful when distributing offloading devices to their patients that features of these devices will impact the patient experience and may ultimately dictate adherence with these devices. One limitation with the present study was that it was not a full factorial design, so we were not able to individually assess the impact of the height of the walker alone. And similarly, we were not able to look at the impact of the lift alone. So this study adds to a growing body of literature that's indicating subtle changes to cast walker designs can result in improved patient experience. And looking forward, if we can optimize removable cast walker features for each patient, we may limit the number of patients for which we have to essentially force adherence by prescribing either a total contact cast or making their removable devices irremovable. Certainly additional research in this area is warranted in patients with active diabetic foot ulcers to see if the results we saw in these patients without active wounds translates to patients with active wounds and with continued use of these offloading devices. Playing off of that, we did just have a case study that was published that really plays off of this concept of making shared decisions with patients and working with patients to find the best offloading solution for them that's going to allow both the patient to use the device and ultimately for their wounds to have healing occur. And lastly, just acknowledgements. I'd like to thank NIH for partial support of the work done in association with the study, as well as donations of the various cast walkers, footwear, et cetera, that were used for this study. And with that, I say thank you for your time.
Ryan, that was fantastic. And it's interesting because we've actually started stocking some of those even ups in our physical therapy clinics because of, those problems. And I can't tell you how many people come in, complaining that their knees and their backs hurt or they feel so uneven. And I'm not sure if anyone has had experience. I've tried wearing the boot. I actually had a mentor that made us wear the boot for a full day, the tall versus the short. And it's extremely uncomfortable and cumbersome, even as like an agile person, it's very difficult to actually ambulate with that. And so having our patients, who are frail, they come in and they bring the boot and then they'll say, oh, I just didn't wear it today. Or I didn't, and you can see that it's brand new and they've never even touched it. It's never even touched the ground. So, getting that information, marrying that with like the smart boot technology, figuring out better ways to stabilize patients, I think for sure, compliance, and then also not causing other morbidities, causing other back issues or knee issues or, other things. So it's really important to provide that education and provide those, provide the necessary tools to help them wear it.
Yeah, it's certainly a challenge when the solution to healing the wounds causing pain elsewhere and the area where they should have the pain. So I think somebody made a comment in the chat today about the gift of pain. So they have no pain at the site of the wound. And then you put them in this boot that's causing pain elsewhere. And obviously it poses a challenge when they're supposed to be in this for weeks and months on end.
Dave Griffin is asking, do you think assistive devices should be more encouraged with either short, knee-high, or TCCs more than we do? They have physical therapists in their TOFLO and GO clinics evaluating these patients. For me, certainly, I think that it definitely should be more encouraged. I did find that during the pandemic, people were actually very hesitant if they don't have like an orthotist on site to provide the boots for them, that they were really hesitant to go to another location, or that a lot of these prosthetic locations were closed. So I've actually been giving people printouts for Amazon or for other things that they can buy online. And the boots are relatively inexpensive. They're about $30 to $45 for the short cam boot. And most people are actually okay with that. They'd actually just rather go, and especially because offloading isn't covered by insurance. The offloading purposes aren't covered by insurance unless they have some sort of sagittal deformity. We found a way to get around that, and we've just been giving patients information on what to purchase on their own.
Yeah, I mean, that's a good thing. I hear that from practitioners across the country, even state to state, right? There's some variability in what's covered and what's available. So that's obviously a challenge at the end of the day for patients. Unfortunately, asking them sometimes to spend $20 to save a limb doesn't always work out the way you might expect it. But yeah, anything we can do to get these devices to patients is a good thing. If the question was alluding more towards assistive devices such as canes or walkers or different things that would make people a little more functional, maybe, it's a good question. I don't know that there's much data out there as far as the impact. I do think that naturally kind of follows up with the concept of not just giving a device to a patient in the room and kind of walking out of the room and hoping that they leave the clinic walking out of there functioning well. So at minimum, just spend some time once you initially distribute these devices and assessing how they walk, how they stand, et cetera, and just seeing if they have any questions, et cetera, to try and make sure at first distribution that it's functioning okay for them is certainly something that merits attention.
Dr. Armstrong is asking, do you think it's better to have someone in a more comfortable offloading device while sacrificing time for healing? What do you think that balance is between the devices?
It's an interesting question, and I don't know. It's always a little bit of the game, right? Trying to work out the pros and cons. I do think you may sacrifice with some of these options actual physical offloading capacity. So you may not have quite as high of, say, a reduction in pressure with a short leg walker versus a tall walker. And our data actually says that, although it's close, you do give up a little bit of that offloading capacity with a short leg walker. The trade-off is if they are being more adherent, is that greater level of adherence going to lead to more healing than what you'd see in the tall leg walker that provides more pressure reduction. But if the patients aren't using it, it's certainly not benefiting them sitting on the floor.
And thank you, Dr. Shin. To follow up with that, you shouldn't give me the ability to mute and unmute myself because I'm just going to continuously unmute. You're going to need a digital restraining order. But Dr. Cruz, that was terrific. You have a manuscript out right now. I mean, I think it was just this last week that was published that really was talking about doing things with people when you're offloading them and not to them, right? And
Yep.
I mean, isn't that the whole theme? I mean, isn't that what has been, right? It's that negotiation. It's like a marriage. It really is with your therapeutic spouse, and it's fraught like with marriage with ups and downs and this stuff is like hard. It's not easy. It's not easy to do. And it seems so simple, right? I mean, you have a sore that is bleeding on the bottom of someone's feet. It should work, that you should just tell them to stay off the thing, but it doesn't. And that's why you're doing this good work. But, I bet that when we, as we speak and as we derive more of these data, we're going to probably find almost a receiver operating characteristic curve balance between some sort of patient reported quality of life and time to healing, even though what we've shown in previous studies has been that it's kind of Machiavellian right now in that the thing that connotes happiness for our patients is actually healing. and they seem to be miserable in so many different devices. But anyway, I don't know if you can comment on all that.
Yeah, I mean, in that paper, we definitely touched about on kind of the evolution of the concept of evidence-based medicine, when, you know, that came out as a buzzword kind of initially. It was strictly, what does the data say, and follow the data, right? But over time, it's taken into appreciation of what patients' wants and needs are, and working that balance of between what's the data say and what do the patients want to do, and finding that best balance. And ultimately, we expect you're going to get the best outcomes when you take both into consideration. What's the highest level evidence state, and what does this patient's desires, needs, et cetera, and work between the two. So hopefully that's kind of the direction of this work, and it'll lead to good outcomes both for the wounds, but also you know, as important or more important for these patients to have good quality of life.
Excellent point, Ryan, what you mentioned. So when I chat with David, I asked David that, you know, when we define adherence, even our definition is quite vague. If the patient don't wear the offloading when they are sitting or they are sleeping, we consider sometimes this as lack of adherence. Sometimes I feel that maybe it's okay to remove the offloading and relax the ankle joint. As you know, offloading lock the ankle joint and may lead to muscle atrophy that can cause a bigger problem down the road for the patient, that is frailty. So what is your recommendation? I'd really love to see the personalization, that you start from knee level and then maybe can having a small transition. But is there any way to even personalize on daily basis to recommend the patient when it's okay to remove offloading, when they should absolutely wear the offloading, and also empower the doctor to decide that how they can recommend to their patient that now this is the best personalized offloading to the patient?
I mean, that's a great question, and I don't have the strongest answer right now because the work needs to be done to really look into it. I would say certainly when lying down or when you're able to lift the extremity, it should be fine to take the cast walker off because you're not loading it, right? Most of the time in adherence, we're talking about during gait, and more so more recently is work you've been doing, and we've been talking about offline here, thinking about not just steps per day, but standing time, right? Because that's a significant factor in how much stress is going to be applied to these feet over the course of the day. But even seated is a bit of a question mark right now, right? Because there's been some studies showing that with just low levels of stress, you're potentially impeding some blood flow down there, and that may not be good for the wounds, even if you're have low level stress continuously for a long period of time. So I think more work needs to go into that, but the concept, I mean, why patients obviously like removable devices is that they can take them off. That's a great question about what's safest as far as when they actually should be told or recommended that these are times when it's okay to take it off. But certainly, again, I would say lying in bed, if you're able to prop your leg up on a couch, et cetera, that should be safe. Seated, obviously, it's going to be lower stress, but again, probably you want to be a little bit careful about sitting down and having your foot resting on the floor continuously.
That's a great point. Actually, as you know, when we provide the offloading, in any way, we reduce the level of activity of the patient. We just have a paper that accepted for publication JAMA that suggests that by wearing the offloading, the level of physical activity, a specific number of steps, is reduced as far as 40% compared to somebody who doesn't have offloading. And definitely that may increase risk of falling for the patient when we have the lower level of physical activity down the road. Do we have any recommendation for alternative if the patient cannot remove the offloading, whether we have an exercise, something that we can retain the muscles for them and hopefully not cause an increase in risk of falling or frailty for this patient population?
Yeah, I mean, that's a great question. There's been a few papers that have kind of come out talking about that right now. I think one of them was a methods paper of an ongoing study looking at exercise interventions in folks with active wounds. Some of the work that we've been doing here in Chicago, and David is intimately aware of it because he's here for the beginnings of it, is looking at cycling interventions for folks with wounds, and specifically how you essentially orient the foot relative to a standard cycling pedal to allow the wound to stay offloaded, but also to use those lower extremities, get some exercise and maintain muscle strength, et cetera. So once they come out of those cast walkers, they're able to resume some healthy physical activity. So I think there are some opportunities out there to help patients stay engaged while they are in these more substantial offloading devices for active wounds. And certainly anything we can do to prevent kind of that downward spiral of decreases in physical activity with each successive wound is certainly likely to benefit these folks.
Well, Dr. Najafi, I think, we're way ahead of our class is way ahead. We started a little early. When does this ever happen? But I'm thinking, do you want to wrap this up? Because I know there've been a ton of questions. In fact, I still have some streaming through, and there's so much to discuss. But look, this has been our first DFCONtinuum, and to the family that's been online here from all over the world, from the Middle East and North Africa to Asia to, of course, to Europe and the rest of the United States and to South America. I don't know if we had any Aussies today, but it's maybe a little early in the morning for them. But that's no excuse, you Aussies. The fact of the matter is that this is a worldwide problem, not just COVID, but the pandemic within a pandemic, and that's diabetes. And the diabetic foot. And it's great that we can all come together like a worldwide family like this. Super casual. Dr. Shin just took off back into her clinic to take care of patients. That's where we're all kind of headed in various sorts of things. And when you get back into the rest of your day, I think maybe you can reflect on a lot of this stuff, and hopefully some of the stuff that we can do, like I said before, and like we said before, can help people move through the world a little bit better each and every day, in every continent around the world. So on behalf of all of my friends and coworkers around the world from DEF CON and the DEF CON family, we want to say thank you to all of you. You are so welcome to our next DFCONtinuum, which is going to be in February. Check the DEF CON website. We would also welcome you to join the American Limb Preservation Society at limbpreservationsociety.org. Check that out. That's my only kind of pitch on that, but stay tuned. And listen, onward and upward. Here's to making a difference, you guys. Take care.